So let's look at promoting bowel elimination. Let's just talk the poop. Um, this actually comes from Fundamental Concepts and Skills for Nursing, the information. And I want to thank Dr. Kristy Rowley because she's who created this actual PowerPoint. And now I'm just going to lecture on it. Let's get started. So AMP of the GI system, we've already kind of looked at this, but I've just brought it back again because understanding our anatomy and physiology really helps us understand what's going on. So primary organs, we have the mouth, the pharynx, the esophagus, the stomach, small and large intestines, the rectum, and the anus. And as you can see it over here in the picture to the right. So there are other organs out there that really help support our GI system. These accessory organs are our gallbladder. They store bile that helps break down food. Liver, I have a ton of jobs to do. It does a lot. It is huge. It is one of our filters. It just does a ton of different things for us. And the pancreas with pancreatic enzymes. So this is very important too. And we'll learn with diabetes how the pancreas plays into that role and everything else. But our accessory organs do a lot. So go back, review your anatomy and physiology always so you can understand what's going on. So what are the functions of the intestine? Well, they absorb nutrients, of course. They're absorbed into the bloodstream from the villi that aligns the wall of the small intestine. And then also the functions of the intestine is it goes through absorption of nutrients, and then we also then create all of that waste material and elimination of that. Here is another word that you should know is functions of the GI system is to absorb. We need to absorb. So how does it start? We eat, right? Mastication is teeth, tongue, and chewing. We'll have our mouth. It'll go down the pharynx, through the esophagus, into the stomach. Secretion from the cells inside the stomach wall mix with food and form chyme. So let's stop and think about this. So what makes up that? The pot down there has chyme, and there is mucus, intrinsic factors, pepsinogen, gastrin, bile, which comes from the liver, and hydrochloric acid from the stomach. We put this all in the pot, and what does it do? It forms this so that we can start to break down the food that we intake so that it can start the process of going through the intestinal tract so that we can absorb the nutrients that we need. So what happens is digested food, and we break down there in the stomach with all that good stuff, goes to the small intestine, and we absorb. It enters through the bloodstream through the intestinal villi, and then it goes to the large intestines and absorbs again, and then we eliminate. Waste is rectum. So when we get to the rectum, it is all waste. There is no absorption there. It is bye-bye, baby. It's gone. We're going to actually have a bowel movement. So this is important to understand. It's a process that starts high. So if we have a patient that has issues with even chewing or getting food into the system, that can be a breakdown that can actually have an impact on our GI system. And because we're not able to absorb the nutrients that we need in the small intestine and then go on through to the large intestine, then we will end up with issue. What we normally see in the large intestine when we absorb is the water from stool, the more of the liquid part, because that's why we get a more solid stool as we have our waste produced. So, functions of the intestine. Let's talk elimination. We've been talking about it, but let's talk about it with the GI tract now. So, of course, absorption, and we see a lot of absorption through the blood, through the villi of the small intestine. We still have absorption down in the large intestine, but we have elimination that comes from that. It's the elimination of waste. This is how we get rid of our toxic materials after what we need is absorbed out of what our nutrition is, and then it needs to be processed and come out. If we can't get it out, it can become lethal and deadly. So bacteria breaks down the waste products in the large intestine, peristalsis is taking place, and peristalsis is how or why we hear bowel sounds. So when you're doing your assessment and you're listening for bowel sounds in all four quadrants, you should be hearing them because peristalsis always is taking place. And now in a few minutes, you're going to see in the next slides of when it's faster, when it's slower. We even had this question in clinical recently is, they just had a bowel movement. Would it be this? Would it be that? You should be able to hear bowel sounds at all times. If you don't, there is a problem or an issue and it needs to be addressed immediately. So this is actually a blank screen. I know it is. I'm looking at it. But there is, oh, here it is. It came up. So this is it, and I will include this link when I post for my students, but this is a link on how the bowel works on YouTube. So you can click on the link, hopefully, and if not, I will include it in my information of this actual video lecture on YouTube. So you can access that. For my students, I will put it on the sheet that I post for you to be able to connect to the link so you can watch this quick little video. It's like 2 minutes and 23 seconds. So functions of the intestine, elimination of our waste. We've said that. The Valsalva maneuver is intra-abdominal pressure increases when a person holds their breath, closes the glottis, and tightens the abdominal muscles. So we kind of see that's what they're doing. Do you see how we're doing it? It also can cause a cardiac response. So we never want people to bear down, hold their breath, do those things and push, because what happens is they can actually stimulate the vagus nerve. And when they stimulate the vagus nerve, it can cause bradycardia. And that is not a good thing. So if somebody is going to the bathroom and they need to strain, if they're sitting on the toilet, you don't want them to bear down and push and we don't want that, because what happens is we can cause the vagus nerve to become stimulated and it can cause them to brady down. Now there's other ways we can do that, but this is one way, and this is why lots of times when you hear a code, we go to a code response in the hospitals, is usually we'll find lots of times we will find people in the bathroom, and what usually has happened is they're already compromised. They bear down, they vagal down, and then they can't bring that heart rate back up, and they go ahead, bottom out blood pressure, and arrest. So there's ways of doing this, but this is a lovely little picture over here showing the muscles and how we can do the Valsalva maneuver. So let's look at assessment of the GI system. You gotta love it. So data collection. When we're looking at the GI assessment or the gastrointestinal assessment, we need to collect our data. One of the things you want to know is, when was your last bowel movement? We need to know that. These things really tell us a lot about a person. There are people out there that do not have bowel movements for weeks. I am not about that. I think that should be every day, if not twice a day, is good for the body system. But anyway, when was your last bowel movement? Do you have any problems or issues with having a bowel movement or with your GI tract? When you look at this, do you look at your stool after you go to the bathroom? If you do, what does it look like? Because different appearances of stool can speak volumes to different things that are going on with our body. So it's good to ask, what does it look like? Because if there's been a change, we need to know. Determine usual bowel pattern. Some people drink their coffee in the morning and then go to the bathroom and have their morning constitution. That's what I do. And then, and other people wait all day because they don't want to go to the bathroom in any bathrooms and then come home and go to the bathroom and have a bowel movement. So everybody has their own bowel pattern. And so it's nice to know when, because if you have a patient in the hospital and they need to drink a cup of coffee or so a warm beverage every morning so they can have their bowel movement, then we need to make sure that we include that in their regular activities of daily living. They have a cup of coffee and then get them to the bathroom. Medications. Do you take any medications for your GI tract? Do you take any to have a bowel movement? Do we take laxatives, stool softeners? Do you take any kind of Pepsid or anything to help with reflux? Anything like that, we need to know. And this is the time to ask it. Diet habits. Do we eat a lot of fast foods, junk foods, things that are not good for the GI tract? Or do you eat a lot of fruits and vegetables, green leafy vegetables, things that will, high fiber foods that help with bulk of stool? Those are the things we want to know. And then if they have any disorders or diseases that have already been um, doctors already diagnosed for these people, we need to know if they have any disorders or diseases. So let's look at gastrointestinal assessment, physical assessment. What's the first thing you want to do when you assess anything? We want to look, we want to inspect, right? That is the first thing we do. So you want to observe, look at the abdomen, look at the shape, have the client lying supine, and we want to looking for scars, marks on the abdomen, anything to lead to more clues or information that you need for this to be able to help with this patient's assessment and hopefully help with their care. If you see anything, ask the patient, hey, why do you have a scar here? And they'll probably say, well, 20 years ago I had this surgery. Or they could say, I was in a motor vehicle collision and I ended up with this, or I was sawing down a tree and this happened. I mean, you get a story, but the story tells you things and you can start to put the pieces together. Secondly, we want to listen. We never touch the abdomen until after we listen. So we're going to auscultate vowel sounds starting on the lower right quadrant, and we go lower right, up, around, all the way back to the lower on the other side on the left. Then we'll palpate gently for masses or tenderness in all four quadrants. When you are doing this, you should be looking at your patient's face as you look at what you're doing, and then look at your patient's reaction. Because if they're grimacing, or they're looking away, or they're crying, that is a clue that something is tender or going on. Also, when you're doing this, please explain to your patient what you're going to do. Say, I'm actually going to assess your abdomen or your stomach, base it the lingo on what your patient, where they are. And then say, I'm just going to feel, but please let me know if anything hurts, if you feel any tenderness or pain. And then if you do come across something, it doesn't mean keep digging your fist to their spine. It means to stop, how does it feel? You're going to dig deeper for more information so that you can let the physician know that there's tenderness in the spot. Remember too, when we're assessing anything with nursing, we always use a clock, right? 12 o'clock top, 6 o'clock bottom, 3 o'clock right, 9 o'clock left. So we would put it on our clock, the whole abdomen, and we could say 2 o'clock, upper right quadrant is this. Here it is again, 4 techniques in special order. We want to inspect, we want to auscultate, we want to palpate, and then we percuss, where we tap our fingers over. If it's air, it's going to sound like a drum. If it's fluid or blood, it's going to be a dull sound. And there is a difference. As you're in the clinical setting, as new nursing students, get out there and percuss, because you will hear the difference. You will hear the difference as you percuss at different areas. Put it over a bone or put it over something that's not hollow, and tap, percuss with using your fingers in the other hand, and listen to what you hear. Then go over something that's hollow or something that there's air involved, and you'll see then hear the differences. But it's a great thing to do, and it's a great thing to practice. So do it on every patient you come across. So we're going to inspect. What are we looking for? Symmetry of the abdomen. Is there any distension? Is one side distended more than the other? Skin color, skin folds. We're going to look if they've got a pannus, that flap that comes over the belly that hangs down. You want to lift it up and look underneath it. We want to know. Lots of times yeast grows there. Skin will break down, same as under the breast, but we're doing the abdominal assessment right now. But we want to look in under all the skin folds. If they have other folds that are on the abdomen, they're larger or something, you must lift up and take a look. We're also looking at color. Lesions, are there any hernias? Do we see anything bulging out? That's a hernia. We need to know. Discolorations on the abdomen. Do we see any bruising? Do we see any petechiae, which is a little red kind of rash looking thing? Do we see anything? We need to know. Edema. Ascites equals fluid in the abdomen. So if you see the word ascites, that is the fluid in the abdomen. It's the swelling in the abdomen. So we're looking for that. It's indicative of things going on. Liver failure patients usually have a lot of ascites. So bowel sounds, they're soft gurgles and clicks. We hear every 5 to 15 seconds, there should be a bowel sound. So it's peristalsis. If we have diarrhea or something like that, it can be faster and louder, just depending on what's going on. Normal is 5 to 30 in 1 minute. That's normal bowel sounds. Hyperactive bowel sounds are loud and frequent. And then hypoactive bowel sounds are no sounds at all in the 4 quads for 30 seconds. And then you cannot say a patient has an absent bowel sound unless you have listened for 5 minutes in each quadrant. So if I listen to one quadrant and I hear some tinkly sounds, I call them tinkles, you hear that gurgling, clicky sound. You go to the next quadrant and you hear it. So you have bowel sounds in, right lower, right upper. We get to the left, and let's say we have bowel sounds in the left upper, but we get to the left lower quadrant and we listen and we listen and we don't hear anything. You can't say there are no bowel sounds in that quadrant until you have listened for a full 5 minutes. After that, if you have not heard anything, it's considered an absent bowel sound. Now, sometimes people will have aneurysms. So when you're listening, you might hear a swishy sound. Swish. Those are vascular sounds or bruits. And that is usually indicative of an aneurysm if we hear that. If you hear a swishy sound like that, you need to call the provider immediately because an aneurysm is can be a life-threatening issue or event. Hypoactive bowel sounds are indicative of constipation, blockage, or post-surgery because when you have surgery, we give you anesthesia, and anesthesia makes everything go to sleep. The lungs go to sleep, the bowels go to sleep. And then when you wake up, everything has to wake up, but it doesn't just hop out of bed and say, let's rock and roll. Instead, it takes time. So sometimes post surgery, the bowels have to wake back up and they can be slow and they'll be hypoactive. And that's why we need to make sure we give stool softener to surgical patients. One, because of that reason, and two, because of pain medicines, because pain medications cause slower peristalsis and hypoactive bowel sounds. Hyperactive bowel sounds is diarrhea. Diarrhea. And we'll learn a lot about diarrhea come Monday in class. This, once again, to reiterate, we're going to lightly palpate over each quadrant. I don't want you putting your fist to the back of their spine. We don't want to do that. We would injure the patient. Detect tenderness or masses if you feel anything that's abnormal. And while you're doing this, you need to watch your patient's face to detect discomfort. So let's percuss, used by providers, not nurses. Percussion is usually used by providers, not nurses, but nurses can. We teach you to do it, and it's something to do to listen to. I think all nurses should do it. I don't usually document if I do it, but if I do find something that's abnormal, I will let the doctor know. Place middle finger on one hand on the abdomen and strike finger lightly below the knuckle. Listen for changes in sounds. Dull thudding sounds are heard over solid organs. Already kind of discussed that. But just note when you're actually doing your nursing note or you're doing your nursing assessment, you don't have to percuss and document that. We don't normally, you won't see it when you're filling out your Epic charting or any electronic charting. It's not going to ask for percussion. It is a skill that we teach. It is something you can do. And what you need to know is that when you do it, what you're listening for, so that if you get something that should not be, let's just say I've got a distended abdomen, I'm percussing and it's a dull sound. That would say to me there's fluid, something's going on. Is it blood? Is it fluid, ascites? What is it? Something's happening. So that's percussion. Now, this little slide talks about the gastrointestinal system differences between children and adults. So at birth, the resistance of newborns' intestinal tract to bacteria and viral infection is incompletely developed. So they're developing when they're born, their GI tract is still in process of developing. As a child grows, they have higher nutritional, metabolic, and energy needs. You know that we have to eat. Children want to eat all the time, right? They're hungry, 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 and they'll eat everything they can find because they're in the process of growing. Their metabolic need and energy, there's needs there. So they'll go through spells where they're not hungry at all. They don't want to eat and they eat very little, almost like a little bird. And you're worried. You're like, oh my gosh, they're going to starve to death. But it's not. They don't need it at that time. But they'll go through a spell where they'll do that, and then the next round it's eat everything in sight. You can't fill them up. Children with nausea and vomiting dehydrate more quickly than do adults with those symptoms. Write that in your notes. Write that in your notes, and you need to be telling everybody that has kids. If a child has nausea and vomiting and diarrhea, put that in there, they will dehydrate more quickly than do adults with those symptoms. Infants can dehydrate within 24 hours. 24 to 36 to 48, we need to be doing Pedialyte or getting something in them. Same with small children. We just need to know that they dehydrate faster. So we can't wait. We can't wait to intervene. We need to be on top of it. The infant's stomach is small and empties rapidly. That's why they have multiple bowel movements throughout the day. Newborns produce little saliva until 3 months of age. Swallowing is a reflex for the first 3 months. Hepatic efficiency in the newborn is immature, sometimes causing jaundice. So the liver is still developing. It's immature. It's still developing. So that's why our whole GI tract, that's why babies get fussy and have sore tummies, and you're having to, be up all night because they're crying. They're just never, it doesn't feel good. They just don't feel good. It hurts. They're in the process of developing and they're trying to process either breast milk or formula for nutrition. The infant's fat absorption is poor because of a decreased pool of bile acid. So the bile is connected to the liver. And if we don't have enough bile to break things down, to break fat down, our fat absorption is poor. So that is something to understand. So put all this in your notes, but mainly know right now, children with nausea and vomiting dehydrate more quickly than do adults. And then all the rest. You've done growth and development, and this is just a little play more into that GI assessment. So pregnant women, constipation are common in pregnant women. They get constipated very easily. The growing fetus can interfere with peristalsis. There's pressure. It just doesn't do well. Prenatal vitamins with iron. Iron is a constipator, period. If you take iron, adults take iron, whatever, it can be a constipator. And the other thing is actually progesterone, and the increase in progesterone will slow peristalsis. So there's several things, but pregnant women are more prone to be constipated. So what do you think we want to tell a pregnant woman? You're more prevalent to be constipated, and how do you fix that? Drink more fluids, increase your fluid intake, try to introduce high fiber foods into your diet, and mobility. Move and try to walk around, because gravity and mobility is your friend. It will help with peristalsis and moving things down and hopefully down and out. So this one really makes me laugh. It's an older gentleman sitting on Santa Claus's lap saying all he wants for Christmas is one really good bowel movement. So when we're talking about assessing and the changes that we see in different lifespans, older adults, we have atrophy of smooth muscles, we have reduced mucus secretions, and we have reduced tone in internal and external sphincters. And just so you know, atrophy means decreasing in size. So the muscles are decreasing and going away. So we don't have a lot of control. We'll have constipation. We're not able to get those things down and out. So diagnostic assessment is another. We do stool tests. There's an at-home stool sample kit and test. You can do it there. You'll get your own stool, put it in little containers, send off to lab. There's an occult blood, parasites, and fecal fats. Fecal fats are steatorrhea, and we'll learn that here in just a second about all the different kind of stools and what there is. That's if you see steatorrhea, it means fatty stools. We have imaging, x-rays, endoscopies, and EGDs, and capsule endoscopies. So as we're talking about diagnostic testing, if we're doing an endoscope, we are actually going to be consciously sedated. So when it's time to come, the patient's done with their endoscopy, we want to make sure that their gag reflex has returned prior to offering fluids. Same with surgical patients. If we paralyze or sedate in any way someone, they can lose their gag reflex. And if we gave them fluids before it came back, they would aspirate the fluid in their lungs. Don't want that. It's a bad thing. So diagnostic assessment. If we're doing a colonoscopy, we start now at the age of 45 years old. Every 10 years is the expectation that you will have another colonoscopy. So 45, 55, 65. Now, if there's anything wrong or there's any issues or there's a history of anything, the physician might want them to come earlier than that. It could be yearly, every 2, 3, 4, whatever, depending on the situation. We want to avoid aspirin, any anticoagulants or antiplatelets. Those are things that can make us bleed. If we're doing a colonoscopy, we want to avoid red, blue, purple, orange drinks and gelatin because they can look like blood in the GI tract. So we want to make sure that none of that's been introduced into the system. And the client should be placed on their left side with their knees up. And there are some pictures over here that you can look at, and these are some others that we can do, ultrasound and a sigmoid. So those are the ones that we can also do for diagnostic assessments. So let's talk about poop. Stool characteristics. Normal stool should be light to dark brown, soft, formed for children and adults. For infants, it will not be. It will be more of a loose stool, but for children and adults, it's formed. Infants, it can be yellow, and like I said, unformed. It also can look seedy, like there's little balls or seeds in it. That is normal. Newborns, we will have meconium, which is a meconium stool, which is a sticky, odorless, very dark olive green or black stool. And that is the stool that is in their GI tract. Sometimes when they're in the middle of birth having this baby, the baby can have their meconium stool in utero, and that can become very dangerous because if they take their first breath once they're born, they could inhale the meconium and cause a meconium pneumonia, which can kill them. So we want to make sure that if you see a meconium stool, you know, while a baby is being born or on the baby after the baby's born, we want to be very, very careful, make sure we suction them very carefully, thoroughly, so that they will not inhale meconium, because that can be a killer, an infant killer. Remember that stool is always influenced by diet and metabolism. Formation occurs in the colon. So formation of stool will occur in the colon. Smooth muscles in the GI tract stimulate the peristalsis. We have that wave-like motion. The large intestine is 5 to 6 feet long, 2 inches in diameter. It's a biggie. Mucus in the intestine lubricates the wall, which aids in passage of the stool. So when we're looking at GI stuff, there is a chart that we can use to help identify different stools. So if it's separate with hard lumps like nuts, hard to pass, that's a type 1, all the way to a type 7, which is a watery, no solid pieces, entirely liquid. GI docs will use the Bristol stool chart. We don't normally use these in our own assessments as far as nursing, but it is a nice thing to be able to read through for you to be able to describe what stool looks like. So I put this in, Kristy put this in the slideshow. Abnormal stool. Of course I'm abnormal. Life's more fun that way. Oh, that's too cute. So next we have it. If you see fresh blood, it's red in stool. That's what fresh blood is. Occult blood is old blood. It's dark black in color. It has a sticky appearance. Causes of blood in the stool can be a hemorrhage from ulcers or inflammation or irritation of the bowel. Pale white or light gray stool is absence of bile in the intestine, and you will see that. Another time you can see actual a white kind of clay looking is if we have taken contrast. So if any person is drinking contrast for a test to be run, you need to make sure that they drink plenty of fluids after that so they can flush their system, because it could actually block their GI tract. So let's match the stool color. So green meconium stools, that olive, dark green, black, that's meconium. Meconium stools are usually made up of substances that line the digestive tract during pregnancy. They are what newborn babies have during their first 2 to 3 days after birth. Sometimes they'll even have the meconium stool during birth. Then we have a fast bleed, lower GI bleed, or hemorrhoidal bleed. That is a red blood. We see it's in lower system. You're going to see bright red blood. An upper GI, if we're in the upper part, it has to come through the whole intestinal tract and then out. It's a slow bleed. We're going to have that kind of black tarry stool. No bile is the light white colored stool. Infant stool, often seen in breastfed babies, is a yellow. It can be seedy looking. And then brown stool, of course, is healthy stool. So abnormal stool, let's keep going. Large amounts of mucus, that could be inflammation of the inner intestines. Large amount of fat is steatorrhea. It's the stinky floaters that we see in the toilet. Is a fatty stool. Purulent material is drainage of an ulcer or infection. That's the pus that we can see present. Worms, tapeworms, pinworms, or roundworms. These are all abnormal. Match the stool. So we have mucus, as we can see. I see steatorrhea. It's the floating stool, the fatty floaters, and we have worms. Do you see the worms crawling down here on the bottom? So if you see anything crawling around, we know that this patient would have worms. And we do see worms, especially sometimes in children, depending on certain areas of the country. So this is another video for you to turn on and watch. I will include it also in the information bio on the YouTube channel, and I'll also include it in my posting for my students so you can watch it. And this shows you all the different stools. It's a good thing to watch. So hypoactive bowel sounds and constipation, absence or reduction of peristaltic movement, that's what it is. Constipation, look at this. The picture speaks volumes. You've got your whole colon there, and then you have a lockdown at the bottom. You just can't have a bowel movement. Why? Immobility, number one. We've got to move. We're supposed to be upright and moving. That's what we're made to do. Post-surgical, we can have paralytic ileuses. It's manipulation of bowels during surgery. If they go in, we can have that. Also post-surgical, we can have hypoactive bowel and constipation due to anesthesia because it puts everything to sleep. Your lungs go to sleep, your bowels go, everything in the body stops. And so when we come out of anesthesia, it has to wear off. We have to process it and get it out of our system, and everything has to wake back up, and that's including the bowels. So we will never give anyone anything to drink until we can hear bowel sounds post-surgical. They will vomit if you give it to them. And the other thing is post-surgical, we give pain medications because they have been cut on. And so people are in pain. So we want to give pain medications, but pain medications will slow peristalsis and cause constipation. So the thing you need to put in your notes is that pain medicine causes constipation. And so anybody who has surgery needs to take a stool softener. Lack of dietary fiber, and I would advise you to go back and just look up what is fibrous foods out there in the world. And lack of fluids, dehydration. We have to have fluids in our system to be able to make normal stool. So hypoactive bowels and constipation, once again, the elderly, we see it with the elderly. We get lacking in muscle tone, excessive worry or anxiety or fear can cause this. Certain medications, there is a page number in a box that will not apply for my students. Certain tests, barium x-ray studies, and ignoring the urge to defecate. So you need to go, but you don't go. You hold on to it, hold on to it. If you keep holding on to it, you're going to hold on to it. You'll become constipated. And age. As we age, all of these, that lack of muscle tone, the peristalsis slows down, medications we take, all of those things happen. And the lack of mucus or the decrease in mucus, those things are what help us have normal bowels movements. And so as we age, we're going to have issues with hypoactive bowel sounds and constipation. So how do we promote regularity? We pay attention to the urge to defecate. We eat a diet high in fiber. We keep hydrated. We exercise. We try to poop on a schedule. We drink coffee, prune juice, hot water with lemon can help. So just remember those things. So if you have a patient that's worried about having a bowel movement, just remember you can encourage them to eat high fiber diet, keep them hydrated, give them fluids, get them moving around. That is the best thing you could ever do for anybody. And then make sure that they go sit on a toilet and try to go to the restroom. Offer them the coffee, hot drinks if that's what it takes for them to go. And just remember, we can give medications if needed to get someone going back on a regular basis. So remember, there's considerations we need to take. GI and having a bowel movement isn't something that we're like, hey, everybody, come on in. I'm going to sit down and have a poop, right? No, privacy is important. We need to provide privacy. No one wants to sit and have a bowel movement in front of you as you watch them. Positioning of the client, it's important. If they can't sit up, it's harder to have a bowel movement laying down. So if they can't sit up, putting them on the bedpan or can't get up to the toilet, a bedside commode closer can help. If they can't even get out of bed, we can use the bedpan, but try to put the bed up so that they're more upright in a sitting position. No bowel movement in 3 days, you need to assist with elimination. If they haven't had a bowel movement in 3 days, it's time to intervene. We're going to have to do something. We need to give assistance after bariums, x-rays, and examinations. Fluid and laxatives are needed for those barium x-rays. That's the stuff that we can drink, and that will cause blockage. Good hygiene, feces will irritate the skin. So if they are incontinent of bowel, or if they are not able to get back there and really clean themselves after having a bowel movement, we need to make sure that they are very clean and dry back there, because fecal matter is an irritant and will break down skin. Okay, factors that affect bowel elimination. We already talked about age. We've talked about fluid intake. The psychological factors they can play or have an effect on folks. Position during defecation can. If they can't sit up or get out of bed and sit on the toilet, they might have issues. Pregnancy, we talked about. Medications, we've talked about. Diet, they need that high fiber diet. Physical activity, movement, personal habits. Pain can cause a lot of issues and problems, and can stop people. If you've had any surgery down in that area, or after you've had a baby and it's time to have a bowel movement, it's a very scary thing. People sometimes will hold off as long as possible, which will cause them more issues. Surgery and anesthesia, we've talked about, and diagnostic tests. So barium is not our friend. We drink barium, it's like a brick. And I'm not sure if in a slide prior that I said something about drinking. I'm hoping I said barium, and if not, that's what I meant. So barium is like cement. You drink it. If we don't drink enough fluids to follow, we will create a brick within the bowel system, and then we will have a total blockage. So there's common meds for constipation. We have Ducosate sodium. This is one that you need to know. You'll see it a lot in the hospitals in the clinical settings. This is Colace. This is a stool softener. We also have Miralax. As you can see, it's polyethylene glycol electrolyte solution. It's another one, and we drink Miralax. We can mix it and drink it. Those are our stool softeners. Bulk forming laxatives, we have psyllium, which is Metamucil. There are nursing indications to that, and we need to look at that. And we can go a little further into that, but it's a good way to make a drug card is looking at your bulk forming laxatives. Irritant or stimulant laxatives, we have Ducalax, Senecot, they're there, and then saline laxatives, which is your Milka-Mag, magnesium hydroxide. Bulk forming laxatives drink a large amount of fluid to prevent constipation. So if we're doing Metamucil, that's our nursing education indications, is we want to make sure that we give them plenty of fluids while they're taking it, and then follow it with fluids, because if not, it can cause constipation. So rectal suppositories are another thing that we can use to promote bowel movements. Stimulating the inner surface of the rectum and increase the urge to defecate. That's what happens. Forms gas that expands the rectum and melts into a lubricating material to coat the stool for easy passage. Left Sims position is the position we want our patient to be in. We open the package, use a lubricant before inserting a suppository always. Don't just take a suppository and stick it in there. You need a lubricant. Insert along the wall of the intestine and instruct the patient to hold the suppository for at least 20 minutes. So they need to bear down, just kind of hold on to it. Don't shoot it back out at you. They need it to get in there. And if they can hold it, it will melt. It will melt. They will absorb. It's very vascular in there, and they can get what they need. Next, let's talk about enemas. Retention enemas are mineral oil. You need to retain them for 20 minutes. We have cleansing enemas, soap, tap water, or saline, 500 to 1,000 milliliters. You'll hear an order soap suds till clear. That means you just pour it into them, high, hot, and a hell of a lot. We used to hear that a lot back in the day. You don't give more than 3 because you'll deplete electrolytes. And you want to check the temperature of 100 to 105 degrees. Use it on your inner wrist. If you don't have a thermometer, we don't want to burn the inner bowel. Will cause more issues, problems for this patient. Medicated or disposable enemas, they're small volume lubricant in, usually sodium phosphate, which is a Fleet's enema, and you'll hear it ordered that way. Sims position with the hip slightly elevated. Supine can be used if a patient's unable to be in Sims. Learn your positions, folks. Go back and review them. You need to know them. Warm water between 100 and 105 for enemas. Use a bath thermometer or test over the wrist. Make sure, just like a baby's bottle, you don't want to burn them. So flatus is gas. You can have abdominal distension, discomfort, and pain caused by stretching of the intestinal wall and spasm of the muscle layers. Do not make light of gas. If you have gas that's trapped in the upper intestine, it is good. You can have a patient, if they're able to, or a person, lay on a pillow on their bed and allow it to kind of push pressure onto the abdomen. and help with the movement of that gas to come out. Let it go. Better out than in. So next is fecal incontinence. We see it commonly with stroke patients, traumatic injuries, neurogenic dysfunctions. For older adults, medications, cognitive function, constipation, and impaction. So we can see these things. And we'll talk a little bit about why you would have fecal incontinence with constipation or impaction, but we can. So fecal incontinence is leakage of stool while passing gas. That can happen. Look at the little cartoon at the top when you thought it was a fart, but it's a shart. That happens. It can occur with diarrhea, forcible intestinal peristalsis. So sometimes what happens is we think we need to pass gas. We have this pressure, and unfortunately, we have a little stool coming out. And it's a very embarrassing thing. It's something that can be detrimental in a social event. So we need to be very sensitive to people if this happens to them and explain to them that this can happen, and not to feel that way. Bring an extra set of underwear and pants if needed to go into a restroom and change. Different things like that. Help your patient through these times. So bowel training for incontinence. This is something that we can do. Unfortunately, my father had a stroke. He was incontinent of bowel and bladder, and they never did bowel training with him, and they should have because they could have. My mother kind of did it and could get him up, and he would go in the toilet. Assess for fecal impaction. Ensure your diet is high in bulk and fiber. You want to increase the fluid intake so they don't have any constipation. But the training is also toileting after meals. Encourage a pattern. So if they get up in the morning, put them on the toilet, see if they have a bowel movement. Then after they have breakfast, you can try again. After lunch, try again. After dinner, try again. And then before bed. And after a while, the body will get used to getting up and going. It's called a training, a bowel training. Positive reinforcement, provide privacy, of course, and initiate exercise program to strengthen those abdominal muscles. So hopefully they can control incontinence. Let's talk about fecal impaction. So the rectum and the sigmoid colon is filled with hardened fecal material. So what happens is the older adult who is dehydrated is prone to fecal impaction. So we'll have to do a digital disimpaction. If that is the case, you will put on a glove. We'll go up the side of the wall and do a scoop method, removing the fecal matter. So this is a great picture, and I know throughout this for my students, you're seeing citing where it says page this, page that. This actually came from another book, but it's a great, great PowerPoint presentation, and it goes across the board. So I wanted to give it to you. I didn't remove those because if anybody's using this book, there's your reference to that. But this is a picture of digital removal. We have to be very careful with vagal response because when we stick our finger into the rectum there, we can stimulate a vagal response. And remember when I talked about that, can cause a cardiac event. It will cause the patient to brady down, have bradycardia. And if they cannot regain their heart rate and have it go back up, they can end up arresting, if we're not careful, having a cardiac arrest. So this page, I just left it in and thought I would speak about it. It's intestinal obstruction. What are other words for obstructed? Blocked, closed, impeded, clogged, choked, plugged, jammed, congested, stopped, blind. So these are words. So this should kind of paint a picture for you of what's going on when we say obstruction. Nothing's going through, right? So types of intestinal obstructions. We can have partial or complete obstruction. Mechanical physical obstruction, adhesions, Crohn's disease, strictures, tumors, hernias, and we could have barium impactions and intussusception. Non-mechanicals are paralytic ileus, most commonly caused by surgery, and decreased or absent peristalsis. So remember this, mechanical is a physical obstruction, something's blocked the stool, and a non-mechanical is not a physical obstruction, it's instead a peristalsis issue. Intestinal obstruction according to location, high in the intestinal tract, including the small intestine. These are the signs and symptoms. I'm not going to read them out to you. You can read them. And if they're lower in the colon, it can be a gradual onset. You can have abdominal distension, vomiting, abdominal pain, and then fecal odor to breath for a complete obstruction. Here is the truth about obstruction. If we can't get it out the end it needs to come out, it's going to come up and come out the other end. So people with complete obstructions will vomit fecal matter, and that's not good. So intestinal obstruction diagnostic and treatment, we can do an abdominal CT scan or an MRI. Non-surgical treatment, we're going to keep them NPO. We're going to put an NG tube down. You just learned that in Skills Lab, to low wall suction. We're going to have IV replacement, normal saline or lactated ringers. Treatment, we're going to do surgery. We're going to have to go in. We're going to have to remove adhesions. If there's twisting, we're going to have to fix that. If there's a hernia, we'll have to repair that. A tumor, remove. Any of those will indicate an ostomy. So if we have to go in for adhesions, twisting, hernia, tumors, we're going to end up with an ostomy. And even they might be able to bring the ostomy back in and put it back together once everything is calmed down and healed. And sometimes it can be a permanent ostomy. So a bowel ostomy, temporary or permanent artificial opening to the abdominal wall. The stoma is what comes up and comes out of the skin. We see it. That's what we're looking at and assessing. And it should be beefy red. Put that in your vocabulary, beefy red. If I go to the meat section of the grocery store and I look at a piece of beef, it should be a dark red in color, bloody looking. That's what a stoma should look like, a healthy stoma. Surgical opening to the ileum or colon is an ileostomy to the ileum and a colostomy to the colon. And you can see the differences in the ostomies to your right. Types of bowel ostomies and intestinal diversions. Here's a perfect picture of this. Ileostomies versus colostomies. Let's take a look at it. So at the top picture to the left is an ascending colostomy. Do you see where that is? To the right of that is a double-barreled colostomy or transverse colostomy. These colostomies, we have two stomas that come up. It's a double barrel, just like a double-barreled shotgun, right? It's the same thing. We have two that come up, and we see them. They're close to side. So they've cut out a part of that intestinal tract. They've brought both up to the abdomen through the walls of the abdomen there to the outside to form two stomas. A descending colostomy, as you can see, it's coming down that descending colon. Sigmoid is down low. We see it, the ostomy down low. And an ileostomy is in the small intestine. The difference is what we see with stools, where digestion takes place. So we can have a thicker type stool, more looking like stool in a colostomy, and compared to an ileostomy, food won't even be broken down in the ileostomy. We can still see whole particles of food sometimes for things that are hard to break down. This next slide says changing an ostomy appliance. It actually is giving you the skill where it's located in this book that we used to teach from. But for my T students now, I want you to go back. I've asked you to do nutrition through ATI. There's ostomy information there. Please review the ostomy information that's provided for you through ATI. Suppositories. Also review how to put in a suppository. That was through your whole medication administration. Review that skill. And fecal impactions, we'll talk a little more about those, but go ahead and review how to remove an impaction through what we have learned in skills. You might have to go back and review those skills, but please do so because you need to know. I hope that this lecture helps. I know that sometimes page numbers and chapters from different books that are posted on can be confusing. Please don't let them be. Just ignore those, but look at the information that's been provided to you because there is excellent information about the GI assessment and the GI tract. I hope this helps. and I hope you have a wonderful bowel movement. Hee hee hee.